All right, everybody, welcome back to the High Yield Pharmacology Review. This is Mike, and Amina will be talking later. I apologize for not getting this up earlier than we originally planned. Lucky for me, my computer crashed. I hadn't backed it up in a while, so of course everything had to be done again. So you're getting round two of all of my parts. All right, and as always, just a little disclaimer, take everything we say with a mound of salt, not just a grain, because we are giving you our best guess or approximation. So we're, not working with the school. We're just doing what we think is important. So just to start, we'll look at a little case. We have a 48-year-old woman coming in with a history of peptic ulcer disease and GERD, presenting to her primary care because she feels rotten. Also feels tired, weak, and more run down than she ever has before. She also complains of some constipation over the past few days. So that, coupled with these laboratory findings, what medication is most likely causing the patient's symptoms? Well, she's feeling tired, weak, and more run down. This sort of is a bit of a compilation of symptoms that forms part of something what's that word? I'm sorry. A constellation. It forms a constellation that is sort of recognizable. It is only a few of them, but it is possible. Coupled with the fact that she is suffering from peptic ulcer disease and GERD, and if you had an astute eye, you could see that her calcium was about 15, is quite high. She's suffering from calcium toxicity. So, hypercalcemia we tend to see primarily with hyperparathyroidism and parathyroid adenoma. However, in this case, we're seeing it because the patient is taking too many Tums for her disease state management. And sort of the constellation of symptoms I was getting at was the bones, stones, groans, and psychiatric overtones that you can sort of see when you have a patient with hypercalcemia. All right, so with that, we'll talk about gastroesophageal reflux disease and its treatment. So, as the first question alluded to, some of the things we can use are antacids, and there are quite a few different types that work in different ways. So, some of them include sodium bicarb, which is one of the main ingredients found in Alka-Seltzer, calcium carbonate, which is one of the ingredients found in Tums, aluminum hydroxide, and magnesium hydroxide found in Maalox and Mylanta, respectively. So these work by literally neutralizing the gastric acidity. So you take these medications and they work to instantly have breakthrough symptoms for GERD and peptic ulcer disease. They work instantly, and as you can imagine, if you're taking medications that contain calcium and magnesium and aluminum, you could have some electrolyte imbalances. And then another key thing to remember is one of the side effects that you will be tested on that you need to be able to differentiate is diarrhea or constipation. Does this specific medication cause diarrhea or constipation? And we'll get into that with the individual agents on the right-hand side. In addition, you really need to understand that the absorption, bioavailability, and urinary excretion of other drugs can be changed drastically by taking some of these medications because you can alter gastric or urinary pH or by delaying gastric emptying. So, examples. Aluminum hydroxide, you want to remember aluminum causes constipation. Calcium carbonate, another one. We talked about this already. It can lead to hypercalcemia, obviously increasing calcium levels, and so also used as a supplement for patients with chronic kidney disease. Very important point. There are drugs that can chelate or bind to calcium, and it will lower that drug's absorption. And the two that are really important to remember are tetracyclines and quinolones. If you have a patient who, for whatever reason has peptic ulcer disease and they take a ton of Tums, and then all of a sudden they get a little urinary tract infection, and then they start taking ciprofloxacin, there's a possibility that that drug won't get absorbed because it's binding with calcium. Very important interaction. And then lastly, but not least, magnesium will cause your diarrhea. So if you have a patient who's taking an exorbitant amount of magnesium supplements for whatever reason, it can cause them to have diarrhea. And that's something that I believe there was a UWorld question that sort of asked you to differentiate like what was causing this patient to have recurrent diarrhea. All right. Next, I include this picture of our Mr. Parietal cell. Very important because it sort of helps me emphasize a point as to how some of the other gastroesophageal reflux disease drugs work. So we have our proton pump over here pumping out one hydrogen and taking in some potassium. But more importantly, we have some of the other receptors that influence that pump, our acetylcholine receptor, our histamine and gastrin receptors. Now, as we're going to talk about the efficacy sort of the proton pump inhibitors and of the histamine 2 receptor antagonists. So as you can see, the proton pump is what's actually causing the hydrogens to be literally pumped into the gastric lumen. And so if you were to inhibit this pump, it's going to be very efficacious. If you were to give something like ranitidine, an H2 blocker, you're only going to be blocking one of the receptors that then influences and causes an increase in the proton pump. So you could still have influence from histamine or gastrin. So therefore, I don't want to say, very crudely, I want to say, you're blocking the proton pump by 1/3 because there are obviously other mechanisms in play here. But I want you to see the idea that, by blocking the proton pump, you're really having a lot of activity and blocking the hydrogens from being pumped out. Whereas if you're blocking the histamine receptor, there are other ways that the cell can be activated and the proton pump can be activated as well. So strictly back to the drugs now. We have our proton pump inhibitors, which we are going to talk about omeprazole, which is Prilosec. And there are a few others that are not on your exam, but you should know them because you will see them in the future. Esomeprazole, which is Nexium, pantoprazole, which is Protonix, and lansoprazole, which is Prevacid. So these all work by inhibiting that hydrogen potassium ATPase pump we talked about earlier. Used for many things: GERD, peptic ulcer disease, gastritis, stress ulcers, and then Zollinger-Ellison syndrome, which we can see in patients with a little bit of a gastrinoma in the pancreas, secreting gastrin and causing recurrent ulcers. Very mild side effects. Some include diarrhea, headache. You can have some B12 absorption issues, and then mineral absorption issues, specifically calcium, iron, and magnesium. So it's very important to remember that some of those, specifically, I think the best example is iron. Iron requires an acidic environment to bind to intrinsic factor and then get absorbed in the ileum. And so if you don't have that acidic environment, iron won't be absorbed as well. So we caution our patients, or it's important to remember that could impede iron absorption if maybe you have somebody with iron deficiency anemia and they have ulcers, and it sort of clouds the picture. So important to remember. In addition, you can see an increased rate of infections such as C. diff and pneumonia for patients who are on proton pump inhibitors long term. Interestingly enough, so the medication doesn't cross into the parietal cell at the level of the stomach. It actually gets absorbed systemically. So you take your proton pump inhibitor, omeprazole, and within about an hour, it is in your duodenum, crosses over, hits the bloodstream, and then through the bloodstream enters into the parietal cell through a back door. And so it's important to remember that because these don't work instantly. And if you were to take this with a meal, it wouldn't work as well. So the proton pump inhibitors, you actually need to take an hour or two before you have a meal, or what most people do is they have it in the morning. So it's a prodrug, and it's actually activated by high acid. So you're going to take it, and it's actually going to be converted into its active form. Not that it's going to exert an effect in the stomach, but it'll be converted into an active form in the stomach so that when it hits the duodenum, it can be absorbed. There's a drug-drug interaction with clopidogrel, one of our P2Y12 antiplatelet drugs. It's not as clinically relevant anymore. It's sort of been disproven, but they still do like to test this one. So you do want to remember that patients who have just had stents put in after heart attacks who are on clopidogrel, there could be a possible interaction causing their stent to thrombose if they're also on PPIs. And then, as I already mentioned, you do want to give it before meals, significantly before meals, because, let's wait for that to go away, because it is absorbed systemically in the duodenum, not through the parietal cell or the gastric lumen. Next, we have our H2 receptor antagonist. The main one we're going to be talking about today is cimetidine, which is Tagamet. So there are a few on the exam that there are a few that are not on the exam that you probably have heard of. Cimetidine really isn't used much anymore for what I'm going to speak about in the future. So the ones you have heard about are ranitidine, which is Zantac, and famotidine, which is Pepcid. So these are histamine 2 receptor antagonists. And I just want to make it very clear, these are not second generation antihistamines. Antihistamines like Benadryl and Zyrtec, those are first and second generation H1 antihistamines. This is an H2 receptor antagonist, so it works on a different histamine receptor. And just don't confuse those. So these are also used for for GERD, peptic ulcer disease, and gastritis. They're also found over the counter. I just want to make a quick point. So most of the proton pump inhibitors are actually now found over the counter. So omeprazole, esomeprazole, I don't believe pantoprazole is over the counter yet, but lansoprazole are actually all over the counter now. Side effects, very mild: diarrhea, headache, fatigue, myalgias, constipation, and then you can get confusion and renal insufficiency. So that is specific for cimetidine, as well as cimetidine being a potent CYP inhibitor, causing some CYP drug-drug interactions. And also cimetidine has anti-androgen effects that could lead to our very stressful side effect of gynecomastia, or male breast tissue growth. And that's technically why cimetidine really isn't used as much, because of some of these problems. So one of the things I want you to remember are these drugs have some anticholinergic effect, and because of that, in patients specifically with renal insufficiency and that are elderly, there could be a little bit of confusion. All right, so now we move on to some, I guess, funkier agents. They're sort of collectively grouped as the mucosal protective. So the first one is one of my favorite drugs. My second favorite drug, we'll talk about my other favorite drug in the next few slides. This is bismuth subsalicylate, which is Pepto-Bismol. So according to your lecture, we don't really know how subsalicylate works, but there are a few different hypotheses if you want to check out Wikipedia or Goodman and Gilman's. Used for many different things. I'd just like to remember nausea, heartburn, indigestion, upset stomach, diarrhea. But, if you want to be more specific, it can be used for traveler's diarrhea, H. pylori, and, other things. Side effects, the biggest thing you want to remember is salicylate toxicity. Salicylate being, your aspirin-like acid. So this is a subsalicylate. And so if you take too much of it, you can have toxicities. And the big keyword or key thing to remember for salicylate toxicity is tinnitus, or the ringing in your ears. Interestingly enough, it can actually turn your stool and your tongue black. So, it is a pink drug, but the pink in it is dye, because one of the things that goes into drug formulation is, palatability. If you're a patient, would you want to take this? And so, it's sort of black and gooey looking, and so as a patient, you probably wouldn't want to take this. So they dyed it pink, and it makes it look a little bit nicer. But coming out on the other end, it can turn your stool black. So you just want to warn your patients, if they are taking this, that it can turn their stool black. Contraindications include Ray's syndrome. So we wouldn't want to give this to a children who has just had a viral infection, because it is a salicylate. And I will explain a little bit more of that on the next slide. Next drug is misoprostol. So this is our prostaglandin E1 analog. And as we know about the prostaglandins, as they increase the mucus and bicarb secretion in our stomach. So we're actually giving a drug that can increase the mucus and bicarb to lower the acid and to help build up the mucosal lining. So it's technically used in NSAID-related peptic ulcer disease. It can also be used to induce labor. And so because of that, we can see some stimulation of uterine contractions when we give it. So we wouldn't want to give it to a pregnant woman or a woman who has childbearing potential. Some of the other side effects include diarrhea, cramping, and abdominal pain, because it is a prostaglandin, and prostaglandins don't make us feel good. That's why we take NSAIDs, which inhibit prostaglandins. Sulcrafate, our last drug, this literally forms a barrier. So this is a liquid drug that you would drink, and it coats the lining of your stomach. And it supposedly selectively coats an ulcer, but I don't believe it works like that. I like to think of it as a drug that is coating the entire gastric mucosa and forming a physical barrier so that that ulcer can then heal. So it's primarily used in upper GI bleeds and patients who are on NSAIDs for long term who have some of this history of gastritis. It's not very palatable, so it's not used quite as much, but because of its funky mechanism of forming a barrier, they like to test that you understand and know what this drug is. Side effects, it's not systemically absorbed, and it can cause some constipation because it's literally a gel forming barrier that's sort of getting everywhere in your GIT. Contraindications, as always, when we say it's not systemically absorbed, well, that's not technically true. A tiny bit can be, and it is, I believe, excreted renally. So if you have a patient who has some renal impairments, it can really cause some issues and make worse the renal impairment. So renal function, no good for sulcrafate, but for the most part, I think they're really going to ask you about this drug in the sense that what is its mechanism and how does it work? All right, so I spoke a little bit about Ray's syndrome. So this, you'll see it quite a bit if you have aspirin at home. Go look at your aspirin and it'll say, do not give to kids under 12 who have just had a viral infection because of Ray's syndrome. So apparently it is a fatty liver damage that occurs following a patient who has had a viral infection and was treated with aspirin, a salicylate. So because of that, we don't give aspirin to children because if it's possible that they could have had a viral infection, we could cause this. And what exactly is it? It's believed that the aspirin, ASA is aspirin, metabolites reversibly inhibit hepatocyte and mitochondrial enzymes that block bad beta oxidation. And so therefore we get fatty liver damage and yada, yada, yada. So to avoid this, to prevent this, we avoid salicylates such as aspirin or Pepto-Bismol in children who have just had a viral infection. And then the key takeaway is what is the exception? Kawasaki's disease. If you remember that vasculitis and that occurs in children, which the mainstay of treatment is actually aspirin. So the only time you would give a child who might be having flu-like symptoms is in the case of Kawasaki disease when we know we have a patient suffering from this vasculitis. All right. Sorry, just taking a sip of my drink. No. Now, prokinetic agents. These can sort of also be used for GERD, specifically the dopamine antagonist, but they're really not anymore. They're more so used for honestly, they're not really used anymore, but I'll give you some examples and I'll teach you about them. And then I have a few other things I want to tell you about. So your first couple ones are dopamine antagonist, droperidone and metoclopramide, or Reglan. So metoclopramide you may see a little bit. So both of these are dopamine antagonists. And in the gastrointestinal tract, there are dopamine receptors, and antagonizing them will actually increase peristalsis, gastric emptying, and lower esophageal sphincter tone. So if you think about it, you got a full stomach and you have a weak tone on your lower esophageal sphincter, you could technically treat GERD by giving metoclopramide, by keeping everything moving. They also can be used as antiemetics and then also for diabetic gastroparesis. I'll explain why they're not used for diabetic gastroparesis on the right-hand side of the slide. The issue is, lots of extrapyramidal side effects. Some of our Parkinsonian side effects, restlessness, drowsiness, fatigue, depression, and then diarrhea. So they're not really used as much anymore because, we know blocking dopamine doesn't really cause good things to happen. And of course, there would be a contraindication with Parkinson's disease because of the intrinsic lack of dopamine at the receptor to begin with. So this isn't on the exam, but key points that are very high yield. So number one, erythromycin, our macrolide antibiotic, is actually the drug of choice on a test for diabetic gastroparesis. So even though you'll see metoclopramide here and in your lecture on step one, if you see diabetic gastroparesis, you'll click erythromycin. I don't know if you guys have done breast pathology yet, but the example I like to use is, and I just took my OB/GYN shelf today. As I'm recording this, I just took it. And of course, we had this question. You have a woman with a bloody nipple and no other findings. The answer is always intraductal papilloma. Bloody nipple, discharge, intraductal papilloma. So there are sort of, terms that, you can sort of go on autopilot. You see something, you do your scan, you can just automatically find the answer and it's always correct. So diabetic gastroparesis and erythromycin, those terms, that's one of the situations. The next thing we want to talk about is bothanicol. So this is one of our muscarinic agonists, and this one specifically is used for atropine reversal post-op if atropine is used. So it's a prokinetic, increasing gastrointestinal tract, but it also helps with dry mouth and urinary retention. Sometimes you'll see some patients coming out of surgery with a little bit of urinary retention, and bothanicol is one of the drugs that we can use to help reverse this. Another key point to remember for STEP.